So good afternoon and welcome to this session on neurotrophic keratopathy. I'd like to invite the other speakers, Dr. Said and Rashmi, to come and have a seat on the stage. So we're going to tell you something you probably know, but just to put everything together so that we have a clear concept of what this condition is and how we treat it. And to emphasize the role of corneal nerves in every and any corneal pathology. So we've got 3 talks of 15 minutes each, and then we'll have time for discussion. And we'd like to hear from you your comments as well as your questions. So Dr. Dalia Said is a co-colleague from Nottingham. She's a consultant ophthalmologist, special interest in cornea, and is lead of emergency eye care in Nottingham. She will be speaking on the surgical management, so that will be the 3rd talk. I will start with, as you can see, definition, diagnosis, causation, and classification. And Rashmi Deshmukh, who is again one of our very own from India, is now a clinical research fellow in Nottingham. She trained in Narayan Netralaya, where she did her fellowship, and is a graduate from Nagpur. She is doing a fellowship with us, so she will be speaking on medical management. So let's start off with this condition. These are my declarations of interest. So we know that the corneal innervation comes from the midbrain through the trigeminal ganglion and the ophthalmic division of the trigeminal. It terminates at the back of the eye around the optic nerve as the short and the 2 long posterior ciliary nerves. These then travel between the sclera and the choroid anteriorly, and at a variable point before reaching the limbus, they break up into branches. They enclose the whole globe, and radial branches then go to form the pericorneal plexus. From the pericorneal plexus, they will then enter the limbus, and this is a stain called acetylcholinesterase stain of the whole mount of the cornea, which will show you the nerves as brown. And they might be single, or they might enter single and immediately divide into 2, or become straight as 2. And then they move centrally and anteriorly. So they're going from the mid-stroma into the anterior stroma towards the Bowman zone. And you can see that one coming here, and they actually pierce the Bowman's layer and end in a tiny bulb, from which the subbasal plexus or the neurites of the subbasal plexus arise. As you can see here, there are many of these little bulb-like structures. So this is a normal finding of the termination of the nerves that we published in 2009, and then the whole network forms from there. Now that subbasal plexus is in the coronal plane, but from it vertical branches go up, and they are between the cells and actually terminate in modified nerve endings or free nerve endings intercellularly as well as intracellularly. That's what you see over here. Now that innervation of the cornea makes it the most sensitive structure in the human body, 40 times more than the dental pulp, and it's 100 times more sensitive the skin and than the conjunctiva, and 400 times that of the skin. Now the nerves serve 2 functions. One is sensory. We all understand that, taking sensation of the cornea to the brain. But there's also this trophic function, which is very important. So you can imagine a corneal nerve here. It will, through the sensory function, stimulate the Bink reflex and tear production. Both of them are protective reflexes. Tears coming from the tear gland have a lot of growth factors and a lot of bacterial static and bactericidal proteins, and that helps to keep the bacterial flora and maintain the health of the epithelium. The nerves also produce substances called Neuro Mediators. These Neuro Mediators directly are responsible for the health of the epithelium, but not so much the sensory function. It's the trophic function, the health and integrity of the epithelium. And the epithelium in turn produces growth factors, and nerve growth factor is the most important of these, which then helps to support nerve growth, regeneration, and nerve health. So it's a mutually symbiotic relationship between nerves, providing the trophic is also referred to as the nutritional support to the epithelium and the sensory support, and the epithelium supporting the nerves. Now, the cornea is avascular, yet it responds to any irritation or inflammation with a vascular response, and that vascular response occurs in the perilimbal area. Most of the nerves that are in the perilimbal plexus are vasomotor nerves, so they cause intense and immediate vasodilation, and from there then the inflammatory cells can come out and migrate into the cornea. So the ciliary injection is a local axonal reflex. It doesn't go to the spinal cord, and it's immediate, so that when you irritate the cornea by any means, and bacteria, for example, you get intense vasodilation, cells can immediately come out and try and contain the bacteria. But if you don't have that host immune response, you don't have the host inflammatory response, what you see is the bacterial colonies by themselves growing in the stroma, and that is like a Christmas tree pattern, and that's called infectious crystalline keratopathy. That is bacterial or even microbial fungal invasion of the cornea in the absence of the host response. So when there is no innervation or no nerves, you don't get this host response, because you don't get ciliary vasodilation, and you end up with the bacteria going without the polymorphs or the lymphocytes. Now, one thing you have to realize, like I said, if you look at any, so far we couldn't see the nerves, so we were not commenting on them. But here you can see in bullous keratopathy, there's a lot of nerve thickening, regeneration, hyper-regeneration, looping and coiling. You can see in a cornea graft patient, some nerves look normal in the plexus, in the stroma, but the subepithelial plexus is missing, and some nerves are very aberrant regeneration, and some places there are no nerves. So this is what we might call a normal transparent corneal graft, but the nerves are completely abnormal. This is again in a patient with chronic, this is in keratoconus. You can see gross thickening of the nerves, and in advanced keratoconus, outside the cone the nerves are normal, but within the cone they are grossly abnormal, very thickened, too many of them, a lot of coiling. So nerve pathology underlying every corneal disease is a very important factor, but because we couldn't see them, we weren't talking about them. But by looking at corneal buttons that we have removed and whole mount staining with acetylcholinesterase, we can pick up these findings, and also by confocal microscopy we can pick up these findings. So this patient was referred to me with what was called lattice dystrophy, but actually these are calcified corneal nerves and those bulbs. Now from the bulbs, the neuroids don't have a sheath, so they don't calcify, but up till there they are calcifying, and you can see this calcified pattern of the nerves. So this is how it is normally there. What you will also see is that, again, a very important concept to understand, there will be patients with normal kind of distribution, equal kind of distribution in the right and left eyes, but one eye has zero sensation with the Cauchy-Bonnet aesthesiometer, and the other eye has normal sensation. So how can that be? The nerves are okay, but no sensation. And the reason is this: if the lesion is posterior to the ganglion, more central to the ganglion, then all the sensations from here will be blocked here. They won't go to the brain, and the patient won't perceive pain. But the ganglion is intact over here, and the neurons coming from the axons coming from these neurons will go down and provide the trophic support. The neuro mediators are still being released, so this epithelium will not break down. This epithelium will stay relatively healthy. The same happens with a partial ganglionic lesion. But if the lesion is here, or if the total ganglion is gone, then both sensory and trophic factors are blocked. So sensations cannot go up, trophic factors cannot go down. That epithelium is prone to epithelial defects, to stromal melting, perforation, and develop neurotrophic keratopathy. So, but both of these patients will have very poor or limited or reduced sensation. So when the sensations are reduced, if you can get confocal microscopy done, you can see the plexus, you can say that the prognosis is good, but if there's no plexus, the prognosis is bad. So what is neurotrophic keratopathy? The terms we use: non-healing defects, persistent epithelial defects, slow healing defects, and neurotrophic keratopathy, neurotrophic keratitis, or neuropathic keratopathy. All of these are the terms used. So we said we should stick to one. We call it neurotrophic keratopathy. So in terms of nomenclature, that's what this should be called, although clinically they are interchangeably used with the above. The definition of a persistent epithelial defect is an epithelial defect that does not heal or heals and breaks down repeatedly. But the definition of neurotrophic keratopathy is a disease related to alteration in corneal nerves leading to impairment in sensory and trophic function with consequent breakdown of the corneal epithelium affecting health, integrity of the tear film, epithelium and stroma. And the hallmark of the disease is there is lack or absence of corneal sensation. And number of diseases can cause this condition. As you can see, there can be ocular conditions, central nervous condition, systemic conditions, and genetic here, and a lot of diseases and surgical procedures. Increasingly, cataract surgery, definitely LASIK, PRK surgery, corneal graft surgery, a lot of surgery, in fact, any surgery you name, even squint surgery, can be associated with nerve damage leading to NK. In LASIK, PRK, we do this in thousands, but some patients will have the central SPK, not the lower 1/3. We call it post-refractive surgery dry eye. One patient we had where we were able to look at this cornea of a patient with LASIK, and you can see the nerves are abnormal. These nerves don't always go back to normal. So are we really leaving behind a normal eye is the question. Functionally, it is normal, but the nerves don't regenerate. And you have substrate pathology. Sometimes it's not just the epithelium and the nerve, but the keratocytes become depleted, and that will not allow the epithelium to heal. Here is a Canthamoeba infection in an ex vivo model. You can see the trophozoites are actually, this is a trophozoite of a cat eating the keratocytes. That's a half-eating keratocyte. So these stroma is completely devoid of keratocytes. The epithelium will not heal. You get a non-healing defect. And if there's reduced sensation, then that's NK. So there are two things happening: the actual nerve damage related pathology and the underlying cause related pathology. So you always look for the underlying cause and the clinical features of the underlying cause and the clinical features which are directly related to the nerve damage. And this is just a cartoon to show you how if you get infection, trauma, you get an epithelial defect, that leads to keratocyte apoptosis, neutrophil invasion, neutrophils release metalloproteases, stromal melt, and when all of this is linked with poor corneal sensation, that's the start of corneal stromal melting. Clinically, we divide this into mild, moderate, and severe, and is simply put, when there is epitheliopathy without a frank defect and low sensation, it is mild. When there's a frank epithelial defect but no stromal involvement, it is moderate. And when there is stromal involvement in addition, again with poor sensation, it is severe. And these are some examples of mild, moderate, and severe cases. Again, just to show the symptoms can be symptoms of dryness, photophobia, irritability, a bit of watering sometimes in the early stages, or reduced blink reflect. All these will be in the early stages, and then later on you will find they become worse, the symptoms. But as the nerve damage increases, the pain becomes less. The patient thinks they're getting better, but they're actually getting worse because there is no sensory input and the pain becomes less. And then you get frank melting of the cornea, as you see in zoster and simplex cases, and then perforation is a big risk. So that is the severe stage of NK. If you do OCT in these patients, what you will find is that whether it is the mild stage or the moderate stage or the severe stage, there is a lot of stromal involvement right from the beginning. So clinically we say epitheliopathy without stromal, and the epithelial defect without stroma, and then stroma in the severe. But actually stromal involvement subclinically starts right from stage 1. And these are some examples of the mild, moderate, and severe. On OCT, you can see the stroma is involved and melted there, but here also a lot of stromal involvement in the moderate stage. Now, we talk about pain with stain, the classic dry eye. We talk about stain without pain. This is NK, a lot of defects but no pain. And then there is this condition called pain without stain. There's absolutely no stain of the cornea. Everything looks healthy. The patient has severe pain. Many of them are suicidal. It's very difficult to treat these patients. So different terms are used to describe corneal pain, but the the underlying feature of this neuropathic pain, pain without stain, is the activated keratocytes, which may be again mild, moderate, or severe, and then you have this is, you can see a lot of activation of keratocytes compared to that, which is moderate. This is severe, but interestingly, the subbasal nerve plexus can be either completely absent or reduced or hyper-regenerated nerves. So hyperesthesia or increased nerve sensation, we have no way of measuring. We only can measure reduced sensation, and we have to develop tools to measure increased sensation, because that is the cause for pain without stain. And what is also interesting is you have these neuromas in the corneal nerves. This is a relatively new finding. There are different types of neuromas: spindle neuromas, lateral neuromas, and stump neuromas. And these corneas are excruciatingly painful, but there is nothing on the epithelium to show for it. And we try to put the patient off as saying this is, all functional and it's not real and so forth, but there is a problem. So corneal sensation, we should test by testing all 4 quadrants, ask the patient, and also test the cornea and the conjunctiva, because you can get corneal sensation impaired with normal conjunctival sensation. And some patients will have normal blink reflex, and always test the sensation before you put topical anesthesia. So here are different ways by which we examine, but the cotton wisp is the commonest. And what you'll see here is you're looking in the center, to the right, to the left, and the patient may still have some normal blinks. So if your touch corresponds with a blink, you may think it's responding to your touch. But often you have to then repeat it a few times to show where the patient, this is gross absence of corneal sensation. We'll skip this one again just to show the same thing, top, bottom, right, left. So the point here is that nerves are involved in all corneal diseases. Nerve involvement can cause increased sensation or reduced sensation. When nerve is damaged severely, you can get serious pathology of the cornea. All that is NK, but that is often masked by or compounded by the features of the underlying disease, which may be surgery, herpes disease, or diabetes, or whatever. So that is the background of this condition and of the value of looking for nerves and sensations in corneal disease. So I now invite Rashmi to talk on the medical management of this condition, and then we'll hopefully have time in the end, at least 10 minutes we have kept to take questions.
To bring the just one second. Let it be. No, my connector never works. So you need to get your connector.
Should we, I think, should we do the surgical management before the medical?
Because they're not able to connect it.
Yes. Yeah, again? Okay, this one is started. Yeah. Again? Okay.
Sorry about that. Good afternoon, everybody. I'm going to talk about the medical management of neurotrophic keratopathy, both conventional and specific. I would like to thank Professor Dua and Dr. Said for giving me this opportunity in this session. So the medical management of neurotrophic keratopathy is determined by the etiopathogenesis of why the NK has happened in the first place, and also at what stage it is when the patient is presenting and the severity. The therapeutic approaches are guided towards treating the underlying disease process, then treating any concurrent infections or inflammation which is not allowing the epithelium to heal, also preventing the disease progression by promoting the epithelialization of the defect, and providing tear substitutes. And lastly, prevention of stromal tissue loss or any kind of perforation and avoiding further complications of neurotrophic keratitis or keratopathy. So the first thing to do is when the patient presents, we need to see that if the patient is using any kind of topical medications which contain preservatives, then they should be discontinued. And secondly, we should evaluate if patients are on any systemic therapies, the side effects of which are causing neurotrophic keratopathies. So first, about treatment of concurrent inflammation, there are two approaches. One is to treat any coexistent infection which is causing an inflammation, or secondly, if there is any ocular surface disease which is going unnoticed. So for treating coexistent infection, the first thing is to do a culture or PCR of the fornices to see if there are any organisms grown. If it is possible to identify and isolate an organism, and if you get the sensitivities, then according to that an appropriate treatment is given. If no organism is isolated, then a broad spectrum antibiotic topical is advised just to cover all the possible flora. If persistent epithelial defects are there, then one should always consider that there is an underlying secondary infection, and again broad spectrum antibiotics are advised in these cases. And when we are giving any antibiotics to treat infections, we must take care that we are not giving any ocular surface toxic antibiotics like aminoglycosides or fluoroquinolones, which can worsen the epithelium. Secondly, coming to reduction of inflammation of ocular surface which is underlying and going unnoticed, we should look at the eyelids. There can be a possible meibomian gland disorder which is going unnoticed. For such cases, the usual treatment with warm compresses and maintenance of lid hygiene and giving lid massages, these simple things can help. And also we should evaluate whether the lid position is appropriate or not. If there is any entropion or ectropion which is causing exposure and not allowing the epithelium to heal, then surgical management for those can be required. In order to take care of the inflammation, steroids is also an option. Topical steroids are recommended, but in a very low dose and for shorter duration, because we have to be aware that corticosteroids can also adversely affect the epithelial healing itself, and it can also enhance stromal melting. So such patients need more monitoring, close monitoring. And we have to avoid non-steroidal anti-inflammatory drugs because they will also worsen the stromal melt. Cyclosporin is not licensed for neurotrophic keratopathy, but it has been used in dry eye and other ocular surface inflammatory conditions, and it has shown to be effective. So in neurotrophic keratopathy also we can use it. And matrix metalloproteinase inhibitors to prevent stromal melt, again like doxycycline and erythromycin are advised. Then coming to tear substitution, only when the tears are substituted, the epithelium will heal well. So use of ocular lubricants, especially if they are preservative-free products, is advised. They not only help in epithelial cell migration and healing, but they also dilute the pro-inflammatory cytokines which are already present on the ocular surface. And because of the dilution of these factors, the healing is faster. So in lubricants, there are low viscosity, medium viscosity, and high viscosity lubricants. In low viscosity, hypromellose is usually more commonly used as compared to polyvinyl alcohol. In medium viscosity drugs, we have carbomers, carmellose, and guargums, of which carmellose has been shown to be cytoprotective. So Celluvisc or evolved carmellose can be used in these patients. Guargums have been shown to stabilize the phospholipid layer of the tears as well. So the tear film stability improves in these cases if we use Sustain Ultra. Sodium hyaluronates themselves also have been shown to improve epithelial healing. And if high viscosity lubricants are required, then paraffin gels can be considered in these patients. There are other products which are available like liposomes, and mucolytics are specifically used if neurotrophic keratopathy is also accompanied by filamentary keratitis. So in these cases, mucolytics should be used like acetylcysteine, 5 to 10%. There are certain mucin stimulators as well, like diclofosol, which is a 3% product, and it helps in mucociliary clearance and also improves the mucin production. And another drug which improves mucin production is rebapamide. It has not been licensed in neurotrophic keratopathy, but in allergic eye diseases, it has shown to be effective. Then coming to nutritional tear substitutes. So nutritional tear substitutes are all the products which are obtained from blood and serum. Autologous or allogenic serum eye drops can be used. The autologous serum eye drops are available in 20% or 50%. Usually 20% autologous serum eye drops are used. But in cases of autoimmune disorders like Stevens-Johnson syndrome and OCP, there is always a risk of instilling the already existing antigens and antibodies in the blood. So when we are giving those autologous serum eye drops, we can actually introduce those antigens and antibodies on the ocular surface and worsen the healing. So in these cases where Stevens-Johnson's and OCP is there, allogenic serum eye drops are preferred. Other than that, human cord blood serum drops and platelet-rich plasma is also shown to be effective because they have more growth factors, particularly the nerve growth factor, which is effective in neurotrophic keratopathy. Then prevention of stromal melting is another important aspect because we want to avoid any kind of stromal thinning and perforation. So in these cases, matrix metalloprotease inhibitors, they help by scavenging the reactive oxygen species, and also they suppress the alpha-1 antitrypsin degradation. So doxycycline, erythromycin, these drugs are advised. In ongoing inflammation, ascorbate is usually reduced, and that's why the collagen cannot synthesize itself again, and there is ongoing stromal melt as well. So topical ascorbate or systemic ascorbate can be used in these cases, which help in collagen synthesis and rebuilding of the stroma. And it also scavenges the oxygen-free radicals. Topical ascorbate sometimes can be stinging, so in these cases, systemic ascorbate up to from 2 to 4 grams of dose can be used. Then sodium citrate has also been used. It also inhibits the collagenases, and it inhibits the neutrophil degranulation, so it reduces the inflammatory response. And amniotic membrane can be used as a patch or graft, but Dr. Saeed is going to cover that in more detail as a part of surgical management. There are certain specific interventions where drugs have been tried to improve the corneal sensations, and that's how the epithelial healing can be improved. So nerve growth factor is an endogenous protein which helps in differentiation and maintenance of the nerve cells. So there are certain nerve growth factor receptors which are present on the cornea, both high affinity and low affinity, and the nerve growth factor drops are used so that they go and bind to these receptors and help in regeneration of the nerves. So one such drug is called as senegermin, which is a recombinant human nerve growth factor. It is produced by E. coli, and it has been approved in a concentration of 20 micrograms per ml. So the dose is 1 drop 6 times per day for at least 2 weeks, and it has been approved for moderate to severe neurotrophic keratopathy cases. And this is an example showing how there was a response to the treatment with nerve growth factor eye drops. So in the first picture, we can see that there is a epithelial defect with thickened margins, but in the last picture, we see that the epithelial defect is completely healed. Studies have also shown that senegermin has helped in recovery of the corneal sensations in almost 3 out of 4 quadrants of the cornea, and also at the site of the lesion, that is the site at which the neurotrophic ulcer is present. And when there is a restoration of the corneal innervation and sensitivity, the patients often tend to complain about ocular discomfort, which is actually taken as a good sign because it shows that the patient is developing some kind of sensation on the surface. Another drug is regenerating agent, which is also branded as Casicol. It is a matrix therapy agent, and it's a polysaccharide which is engineered to mimic the naturally occurring heparan sulfates which are present in the stroma. It's in the extracellular matrix. So RGTAs, they replace the destroyed heparan sulfate binding sites, and they protect the cytokines and interleukins from proteolysis. Casicol is given just once a week or twice a week instillations, not more than that. The reason behind this is there are very limited sites for heparan binding available in the healing tissue. So if all these sites are already RGTA bound, then if we give any excess RGTA, then it will start competing with the other factors and inhibit healing. Just a mention about the non-pharmacological intervention, which includes therapeutic contact lenses. It helps in maintaining the integrity of ocular surface, and vision is a secondary benefit of using these contact lenses. But if used, then we have to keep in mind that chances of infection are high, so use of topical non-preservative antibiotics is advised along with these contact lenses. So to summarize, the objectives of the management depend on the stage at which the disease is presenting. If it is just stage 1 like mild neurotrophic keratopathy, then the treatment should be directed towards preventing epithelial breakdown and encouraging the healing of the epithelium. If it is a moderate stage, then the epithelial defect has already occurred, so reepithelialization and prevent any progression to stromal melting, so prevention to progression to the severe stage. And if it is already a severe stage, then prevent perforation. This is a stepladder approach to the management of neurotrophic keratopathy, which was published by Professor Dua and Dr. Said. It is a published thing, and this is the table which they have given in that article, which gives you a stepladder approach to how to manage a neurotrophic keratopathy case in the clinic. Thank you very much for your attention.
Right, thank you, Rashmi, and
Thank you, sir.
we'll invite Dr. Said now to speak on surgical management. Just a small point that the nerve growth factor drug Senagermin is actually for 2 months, the treatment, not 2 weeks, but it costs 18 lakh rupees for a 2-month course. So it's extremely expensive, and even our government body, NICE, the National Institute of Care Excellence, has not approved it because it is so expensive. But it does work long term. So you give a 2 months treatment, the nerves regenerate, the sensations come back, and even if you stop the treatment, then it stays healed for a long time, at least for a year.
Yes. Okay, thank you very much. So I'll speak to you now about the surgical management of neurotrophic keratopathy. These are my disclosures. So as Professor Dua has said, according to the classification of neurotrophic keratopathy, it's either mild, moderate, and severe, and the only common thing between the three is reduced corneal sensation. So it's essential that you test corneal sensation for every patient that presents with an ulcer before you put your anesthetic. So when do we actually resort to surgery in these patients? In mild NK, when you have persistent superficial punctate keratitis extensive like in these cases, you can start by doing just punctal cautery because it is much more superior than plugs. And remember not to do plugs or cautery until you have completely controlled the inflammation, because you don't want the pro-inflammatory mediators in the tears to make the ulcer worse. And then the next stage would be surgery to correct any anatomical malposition. So any entropion, ectropion needs to be corrected. Remember the blink leg of thalamus. That is a sign very commonly missed in patients with have inferior neurotrophic keratopathy, where the patient half blinks, doesn't blink completely. And in these cases, you can do lower lid retractor recession, and that will help, especially with thyroid eye diseases. Or you can do medial canthotomy to start, and followed by lateral canthoplasty in leg of thalamus. You can also use gold weights, and the problem with gold weights is that if you don't tailor them properly, they can cause a lot of astigmatism. So you really need to try them out. There are different trial sets which you try them to make sure that you're getting in the right gold weight to put in your upper lid. If there is any mild conjunctivochalasis, it will not make the lids, make the tear film even. So very important to excise any conjunctivochalasis. And remember, when you excise conjunctivochalasis, the patient needs to be looking up so you don't excise too much conjunctiva. So now the next stage would be surgery to heal any persistent epithelial defect, and with or without melting. So stages moderate to severe neurotrophic keratopathy. So these are the different therapeutic approaches which we will discuss briefly in the next slide. So the first therapeutic and easier therapeutic approach is to use Botox or Dysport. Remember, the dose of the Botox and Dysports are different because the Botox has 100 units per mil, while the Dysport has 300 units per mil. So you need to get a 15 to 30 units whichever way from the Botox or Dysport, and it acts by blocking new muscular transmission at the motor end plate. So that's how, and it usually starts to work in 2 to 7 days. In 1 week, it gets the maximum effect. we usually like to inject it along the upper border of tarsus this way, and we found that the complication rates such as double vision diplopia is much less with injecting it on just along the upper border of tarsus this way. The advantage is you can close the lids while you can still examine the patients. It reduces pain because of less exposure of the nerves, reduces inflammation, reducing the tear evaporation, and reduces the rubbing of the lid along the ocular surface. And this is an example of a herpetic patient with post-neurotrophic ulcer, and you can see the rolled edge of the ulcer. We give the patient Botox, and in 1 week, it was half the size. In 2 weeks, it was completely healed. And however, there are complications to Botox. We have seen superior rectus undercorrection in 30%, but in the literature, it can be much more than that. Reduced Bell's phenomena, persistent diplopia, and persistent ptosis, like in this patient which required surgery for the ptosis because the doctor didn't wait until 1 week and he re-injected. So remember, the lids doesn't fall off necessarily immediately. You will need to wait up to a week for the lid to fall. And if you don't see it falling after 1 or 2 days, don't go and re-inject again. Wait for a week before you think of doing any further intervention. The gold standard for neurotrophic keratopathy is tarsophy. So if nothing works, tarsophy will work. So you can do a gray light split, de-epithelialize the posterior lamella, and suture. And we like to always suture over a bolster so that it does not macerate the lids. This is a patient post-stem cell transplant with a non-healing epithelial defect. We put a tarsophy and it completely healed. Now, amniotic membrane can be used, like in this patient. I hope the video works. So this patient had chemical burn, had completely neurotrophic ulcerated surface, and we used Omnigen 500, which is a product off the shelf that is vacuum dehydrated. And you can see here we use two hooks, and we hook the Omnigen under the lids with the 2 hooks. And you can put some drops after you've put the amnion, because if you put the drops first, the amnion will crumble, and then you measure and you can put a conformer, the right sides, to maintain the phonesis. Very useful technique in Steven Johnson's, in acute chemical burns, where patients have neurotrophic ulcers. Again, you can use the amniotic membrane in multi-layer techniques. This is a patient who had an infective ulcer. The infection healed, but he remained with a neurotrophic ulcer, and you can see here. And we put a multi-layer amniotic membrane transplanted here, and we put multiple layers, and we suture only the top layer. And you can see it gets completely incorporated, and the stoma starts to build on top of it. And then epithelialization happened, and this is within 6 months. It's completely integrated, and we've published that when you have breaks in the Bowman's membrane, the keratocytes actually repopulate your amnion and starts to lay down collagen, and the epithelium popularizes on top of it. So very useful technique in neurotrophic ulcers. Now remember that with amniotic membrane, you can get failures, you can get infections, you can get transmission of disease. Whenever we put an amniotic membrane, we like to put a bandage contact lens, but be wary of persistent infection. The infection can get worse if it's an infected ulcer, or you can do a tarsophy to maintain the amnion in place so it doesn't fall off. Another very useful technique is the Conch pedicle flaps, and we use this for neurotrophic ulcer. Once the infection is healed, you sometimes end up with an epithelial defect. And the advantage of the pedicle flap is that you don't have to remove all the epithelium. You just remove the epithelium in the area where there is the ulcer. And the rest of pedicle can go on normal epithelium. And this is another example where we do another technique, which is the free conjunctival graft. So if there is no healthy conjunctiva to take, like in this patient with chemical burn, you can take actually conjunctiva from the other side and then suture it to areas of remaining conjunctiva, and you can see it completely gets taken up. And you can actually use this conjunctiva later on in a later stage to reform the fornix in this patient. This was done together with limbal stem cell transplantation, and the patient had eventually 6/9 vision. So very useful technique to use the conjunctiva from the other side. This is a patient with chemical burn with a neurotrophic ulcer where nothing worked. Tarsophy didn't work. You know, we did a tarsophy, then another ulcer came, then a third ulcer came. So what we did is a limbal to limbus lamellar corneal transplantation, and you can see it healed very nicely. And this is the superior lamella that we glued with fibrin glue on top. and just sutures at the periphery, and has completely taken, and you can see that it's cleared, and you can see that the patient had cataract, and this is how we maintained his epithelial defect. You can also do, if you have a neurotrophic keratitis which has led to perforation, you can do a small therapeutic keratoplasty, where later on you can make a visual keratoplasty. Don't forget about stem cell transplantation. If you have limbal stem cell transplantation and there is no epithelium to restore the ocular surface, then you might want to go for autolimbal or allolimbal transplantation. Now, the direct neurotization is the only technique that is there to actually treat the problem with neurotrophic keratopathy, where you take a sural nerve and use it to connect the supratrochlear and supraorbital nerve from the other side to the eye with the neurotrophic ulcers, and then you make little twigs from the nerves and you put them in little pockets, which you can do with your crescent braid around the cornea, and that will restore innervation. And usually we see that the sensation returns before the actual innervation, and you can see with confocal microscopy that eventually the innervation comes back. A very elaborate procedure, but this is actually the actual treatment for neurotrophic keratopathy. Don't forget that you need to continue with your medical management, your lubricants to protect the ocular surface, also control the inflammation, and use epithelium promoters such as lacrimera or calcicols. So the take-home message, surgical intervention in the early stage, you can do punctal cautery, you can correct the malpositions, any conjunctival chalazies you have to remove. Think of gold weight or lower lid retractor recessions if you have blink lag ophthalmos. And later diseases, later stages 2 or 3, you do your Botox or tarsorrhaphy if Botox doesn't work. And you may want to use amniotic membrane or hooding in the more advanced stages. If there is no stem cell, you can go for stem cell transplantation. And that final is the direct neurotization. Thank you.
So we're happy to share experience if anybody wants to make a comment or has any questions. There's one thing which didn't come out in the discussion so far, is that when you have a problem with the cornea, especially pain without stain, and the patient got a lot of symptoms but you can't find any physical cause for it, put a drop of anesthetic in the patient's eye, one eye at a time, and see if the pain goes away. If the pain goes away, then you know it is surface pain and you can treat it. And we have even used very judiciously, with due caution, topical anesthesia as a treatment to break the pain cycle, and it works. But if you put an anesthetic drop and the patient's pain does not go away, that means it's more central pain, or a peripheral pain is now embedded centrally, and they need pain suppressing tablets, and you have to refer to the pain clinic, amitriptyline or tegretol or something like that, because their pain is more central pain. The other thing to bear in mind is that, like I said, test the conjunctival sensation and the corneal sensation. If the corneal sensations are absent but conjunctival sensations are present, then you know there are nerves in the perilimbal area. Therefore, treatment with nerve growth factor drops, etc., can help those to regenerate into the cornea. But if there is no surface sensation at all, then putting drops will not let new nerves to grow in, because there are no new nerves. So if your trigeminal nerve is transected, or there's an acoustic neuroma in surgery, you've lost the trigeminal nerve, there will be complete loss of sensation, and only treatment there will be, you will have to do direct neurotization from the other eye. There, the local drops will not have a long-term effect. So important to distinguish between corneal conjunctival sensation and the other points that we mentioned, whether they respond to anesthesia or not. Any question here?
When we start treating the microbial keratitis, and after sometimes we have a situation that we don't know that it's the infection which is leading to the epithelial defect, or as you said that every infection can affect the nerves and lead to NK. So how do we kind of go about that?
So if you have, and that's very common, and following corneal ulcers, you end up with non-healing epithelial defect. So you think that the infection is gone, but the defect is still there, and that happens quite commonly. So obviously you will check corneal sensations, and you test them on the ulcer and around, and you will see a difference. So you have to establish whether the sensations have been lost or not. Once you know what you're dealing with, you will have lots of signs to tell you that the infection has been treated. So the hypopion will go, the AC cells will be less, the circumcorneal injection becomes less, the vascularization starts to become less active, the corneal edema settles, the KP start to go if there was some. So all these signs will tell you, and also importantly, the edema outside the area of the ulcer is quite edematous all around. That will also regress. So you know you have treated the infection, and if it is still not healing and you've got a persistent defect and the sensations are low, then you start with all these things, and you will go first with the medical line of treatment, and if that doesn't work, you will try a bandage lens, a punctal plug. When you put a bandage lens in an eye, the risk of infection goes up 11 times. And it is even more if you put a bandage lens in an eye with an epithelial defect. So especially if the patient sleeps with the lens in. So you have to give prophylactic antibiotic, you have to use preservative-free drops and get it to heal. So you go in the step ladder, medical treatment, that doesn't work. Some interventions like Botox or punctal, cautery or bandage lens. And if that doesn't work, then you go into, tarsorrhaphy usually often always works. So that's how we would approach this. But one thing which we tend to forget, that if you are treating your infection with aminoglycosides like tobramycin, gentamicin, amikacin, they are extremely toxic. And you get huge ulcers of the conjunctiva, both above and below, but usually below. And you will get a non-healing defect because of the toxicity. And also prolonged use of antivirals is very epithelial toxic. And there's already reduced sensation and the epithelium won't heal. So you have to stop those and see the response. And there's a little sign we published, the up-down sign. So you ask the patient to look up, the lower part of the conjunctiva will be extremely congested and red. You ask the patient to look down, the upper part is white. Then you know this is toxicity. It is not infection or persistence of the infection, and it's not allergy, because allergy will be all over. So that's a very good sign of toxicity.
Thank you, sir.
Aminoglycosides and quinolines are cardiotoxic. Which is a safer antibiotic you can advise to use?
No, you have to use them, but you have to titrate according to the response, and don't use them for a very long time. So we will start, like for example, every half an hour alternating aminoglycoside and a cephalosporin. This is in a site-threatening ulcer. So the first 24 hours, we are giving them 1 hourly each drop, day and night. So we say that neither the patient nor the nurse gets any sleep. So intensive loading dose. And after that, you have to cut it down. If there's a response, you can straight away cut it down to 6 times a day. And as it heals, down to 4 times a day, and then stop. So you never taper the antibiotics below 4 times a day, because you go to the sub-inhibitory concentration, you get resistance. But if you can get a good effect with the fluoroquinolones, they are less toxic, and the cephalosporins are less toxic than the aminoglycosides. So like your cefiroxim and ceftazidime and so forth. Okay.
Excuse me.
Sorry, what? We'll just take one. Yeah, we started 5 minutes late, but we are just on time. We will take one more question.
Sir, I'm dealing with a patient. 3 months.
Sorry, start again. Yeah, go on.
I'm dealing a patient of NK. 3 months before I have done cataract surgery, and after 3 months, the herpes simplex keratitis has developed. Both endothelium is also involved, stroma is also involved, and epithelium is also involved. I gave him 2 times Predfort and all antivirals, Vitsan gel 5 times and all these. And till that 2 months is over, but there is if persistent epithelial defect is there.
Yeah.
I stopped all Wilson gel and all. There I put on lubricating gels, and but still it is not healing.
Yeah. So what you have to do, and this is increasingly being observed, you get these non-healing epithelial defects following cataract surgery. The first thing is that in the workup, make sure the patient doesn't have borderline dry eye. It's very important to make sure there is if there is dry eye, you have to treat that before and then take a lot of lubrication after the surgery and warn the patient that there's going to be a problem. But you have ended up with a problem. It may not be dry eye related, it can happen without dry eye. And if you're using non-steroidal anti-inflammatory drugs, then avoid those because they will cause rapid melting. And yeah, I'm just saying if as a point of note. But in your case now, you have to use do a tarsorrhaphy. Tell the patient it's going to affect your sight. We're going to do a central tarsorrhaphy, a central ulcer. Let it heal. Put your drops from the side, and if it looks right and left, you can see the lesion and see if it's healing. And once it's healed, then you can open the tarsorrhaphy. So it's like a temporary but an openable tarsorrhaphy. You just freshen the edges, stitch it, and then you can just snip it off.
And I wouldn't use steroids. You need to stop the steroids to allow the ulcer to heal. Yeah.
Yeah, I think that too. Steroids promote melting and promote non-healing. So you can if you want an anti-inflammatory, if you have cyclosporin drops, those would be probably safer. Thank you very much for coming, and I wish you a good Congress.